there will be more that is different between them than is similar. As was mentioned a moment ago, I worked for over 30 years in Cambridge, but 3 years ago, I moved to Nottingham, which, as you know, is in the centre of England. We have a famous resident, Mr. Robin Hood. Here you can see him just outside our department. And if you come and visit me in Nottingham, I'll be delighted to introduce you to him. The group that we have in Nottingham is a translational hearing sciences group. We have basic scientists, we have clinicians, but we are translational researchers taking ideas from the basic scientists and pulling them into the clinic, but importantly, taking ideas from the clinic and setting the agenda of the basic scientists. So it's a full spectrum research group, and really would be very happy to host you if you find your way into the UK. I have a few potential conflicts of interest, consultancies, book royalties. None of them, I believe, are particularly pertinent today. And I still work at least one session a week in the clinic every week, immersing myself in the care of people with tinnitus and hyperacusis. The reason that I'm keen to talk about tinnitus and hyperacusis is there are many myths about them, and many people in clinical practice find them scary. This is a real t-shirt you can buy on the internet, and it talks about how brave audiologists and audiological physicians are. But actually, when it comes to tinnitus and hyperacusis, many of our colleagues are not at all brave and find these patients a real concern. So what I want to do is, with my teaching and my sharing today, is to debunk some of the myths that there are about these problems and to look at some common sense, evidence-based approaches to how we deal with them and understand them. I'm hoping to talk for about 40 to 45 minutes, and then we should have time for questions. I'm wanting to go into issues of definitions and epidemiology, for us to look at mechanisms, for us to look at where tinnitus and hyperacusis converge, but importantly, where do they diverge, and what are the implications for that, for treatment and for clinically relevant research. So we've got quite a lot of ground to cover, but I hope to be clear and understandable as we go forward. You will have chance to ask questions. Now, we know that the word tinnitus comes from the Latin, but here is the first ever use of the word tinnitus in English. It's from a physician's dictionary published in 1693, and they have a copy in the Cambridge University Library that I was lucky enough to hold. In the 1600s, tinnitus was thought to be an obstruction or an irritation. Interestingly, in this definition, there's talk of the beating of the arteries, so some suggestion of pulsatile tinnitus, and tinnitus can be a buzzing or a tingling. That's rather interesting. We'll come to talk later about somatic modulation of tinnitus and how that relates to hyperacusis. Here are some more modern definitions of tinnitus. One from the United States, from a very formative government report written by McFadden. Tinnitus is the conscious expression of a sound, so one is consciously aware of it, that originates in an involuntary manner, so you hear it whether you want to or not, in the head of its owner, or it may appear to do so. The head is the only part of that definition that I'd question. Patients sometimes hear the tinnitus externally, sometimes elsewhere within their body. At least 1 in 5 tinnitus patients initially thinks it's arisen within the house. It's their heating or an engine sound on the road outside. Here's a definition from myself and colleagues, 2013. Tinnitus, the conscious perception of an auditory sensation when there's no external stimulus. So it's an internal percept. But what are definitions of hyperacusis? I know you've recently had another seminar on hyperacusis. That gives me opportunity to come at things a slightly different way. Let's consider firstly the lived experience of hyperacusis. This gentleman, Dan Malcor, is a rather interesting person in the history of hyperacusis. He runs an internet resource called the Hyperacusis Network, which is an extremely good bulletin board and message board for people to do self-help for hyperacusis. He developed his own hyperacusis when he was at an American football match with his young boys, his young children. They were up in the high echelons of the stadium, and they were close to a loudspeaker that had ripped and was distorted. And Dan was exposed to 2 hours of intense, distorted sound. He knew immediately as he left the stadium that something was wrong with his hearing, and here is his testimony about what happened. My symptoms were severe, and my life was collapsing. In a matter of only a few days, I could no longer tolerate the sounds of life. Even my children whispering to me or turning the sound on my head of the pillow at night was distressing. 2 things I think we get from this. Firstly, that the collapse of sound tolerance can be progressive over a matter of days. It isn't always immediate, like noise-induced hearing loss would be. Second, the experience of hyperacusis has a very large emotional component. The sound of his children whispering was distressing, and that's a tragic image. Here's another piece of lived experience. This is a drawing by a young man, age 7. He's happy for you to see it. He is not autistic. He has not had a head injury. He has not had otitis media. None of the usual medical red flags that you're familiar with hyperacusis. But he does have hyperacusis. And here he's drawing himself to tell us about his situation. Even though the window to the street is closed, the sounds of these vehicles is coming through into his environment and impinging upon him. You can see how the sound, you can see that he is physically uncomfortable. And you can see, I think, that he is emotionally uncomfortable. So sound, intensity, overwhelming, physical distress, emotional distress. That has to inform our view of the hyperacusis experience. And it's come to my mind to consider that the issue with hyperacusis is not that sound is necessarily too loud, but that it's too vivid. This rather unpleasant photograph has had the contrast maximized. So the colors are garish and unpleasant. How would it be to live in a world where sound was vivid, full of contrast, garish and unpleasant? People might talk about loudness, but what they might be referring to is this vehemence of the sound, the intensity, the intrusiveness of the sound, rather than decibels. Because to me, we may have been using the wrong vocabulary when it comes to talk about hyperacusis and disorders of sound tolerance. Now, what do we know about definitions of hyperacusis? The word means a general oversensitivity to quiet sound. Until recently, we thought it was first used in the medical literature in 1938 by Perlman, but recently we've discovered the use of the word hyperacusis in a medical monograph in 1886 that we're just writing about at the moment. In the 1960s, an ENT doctor called Mathiasson wrote about hyperacusis, but used the term hyperacusis dolorosa. Hypersensitive sound causing extreme sadness. This particular vocabulary didn't become widely adopted, but that's rather a shame because, again, it resonates with this experience that people have of hyperacusis, of feeling emotionally distressed, disturbed, and there being a tragic aspect to it. Now, other language that is used that abuts on the hyperacusis experience, well, firstly, phonophobia, fear of sound. There are two problems with using this to describe the hyperacusis experience. One is that it's very commonly used in association with migraine to describe that particular experience that a migraineur has during a migraine attack. Transient and sound is over intense, and they're hiding under their quilt to hide away from light and sound together. The other problem with phonophobia is that it uses the suffix phobia, and it implies that hyperacusis is necessarily a phobic condition. And in some people that might be the case, but in general hyperacusis, I believe that is not the case. And so I think that terminology is unhelpful. And then the word misophonia, this term which originally was used to mean a general aversion to sound, but has started to mean an aversion, a dislike, a response to specific sounds of breathing and eating, human sounds, wet sounds. The problem is usually associated with a member of your family, and that is separate from this general hyperacusis term that we would use. Now, I spoke about the Hyperacusis Network, which was founded by Dan Malcor. They use the terminology of collapsed sound tolerance, which again is a rather helpful articulation of the nature of the problem. Now, as audiologists, as physicians, we are all familiar with the phenomenon of recruitment, that abnormally steep growth of loudness, usually associated with outer hair cell dysfunction, though neuroscientists are now thinking that there is a central component to this as well. In the clinic, how can we differentiate between collapsed sound tolerance and recruitment? Well, a relatively straightforward way to do this is to consider that recruitment, being a physiological phenomenon, does not change with the patient's emotional state. If they're fearful or anxious, their loudness growth is the same as if they're calm. Whereas a person with collapsed sound tolerance or hyperacusis, their sound tolerance issues will be markedly stronger if they're emotionally distressed. Now, this is not a perfect differentiation of the two, but in the clinic, if you're trying to differentiate between these two states, and for some patients, they can co-occur, but if you're trying to disentangle those two, then that emotional issue is one that might be helpful for you to consider using. Now, we spoke about the Hyperacusis Network, and here is a picture of what they've been discussing in just the last few days very helpful, very positive discussions. And if you are needing to send your patients to somewhere where they can be part of a community, then I'd commend this to you. Now, another framework for understanding this is the Topography of Hyperacusis that was produced by Tyler and colleagues in 2014. They considered that there are 4 different types of hyperacusis. One that is differentiated by loudness perception. A second, by the annoyance of sound. The third, fear. And the fourth, pain. Now, there are some strengths to this framework. It does include mention of the emotional dimension of hyperacusis. So perhaps is an improvement on a purely psychoacoustic evaluation. However, it's rather inflexible. And because of that, has some issues. If sound is too loud for you, then of course it would be annoying. If it's painful for you, then you might come to fear it. So these different categories of hyperacusis are not mutually exclusive. They can't be used to really pigeonhole people. I think this is a helpful understanding of the spectrum of the problem, but not necessarily a particularly helpful way of clearly distinguishing between very clearly differentiated subtypes. Now, where it does have some strength is looking at this issue of pain hyperacusis, pain that is induced by sound. And here's a website and an organization that's dedicated itself to researching this, and it's becoming very strong indeed. I commend you to go and have a look at it. It's run by a gentleman called Brian Pollard. I was talking with him this morning about some research we're doing together, and he's building a community of clinicians and researchers to look into this particular issue. So please do go to his website and introduce yourself to him if you would be interested in being part of that discussion. Until recently, we haven't understood how noise could induce otalgia. But colleagues, particularly working in the Massachusetts I&E Hospital under the direction of Professor Charlie Lieberman, have found pain-sensitive nociceptive fibers within the cochlear nerve, and particularly these unmyelinated type 2 cochlear afferent fibers. And here you can see a diagram from Ben Auerbach. This is from a summary article that was in ENT and Audiology News just last year, which is very helpful in terms of looking at these nociceptive afferent fibers running particularly from the outer hair cells, and particularly seen to modulate the experience of loud sound causing otalgia and pain. Now, we should have known that these fibers were present even before Lieberman and colleagues identified them. The exquisite pain that a child experiences during an ear infection, or the aural fullness that a patient experiences during endolymphatic hydrop, an attack of Meniere's disease. The hydrops is building, Reisner's membrane is being distended, and the patient feels a deep pain, otalgia within the ear. That's almost certainly mediated by these fibers that have recently been identified. Now, how many people experience hyperacusis? Well, there are various ways of sampling this. The first was an internet study done in 2002 in Sweden, and that's important because even in 2002, many people in Sweden had access to the internet. They used a very wide definition of hyperacusis. Does sound ever evoke discomfort or pain? And nearly 1 in 10 of the respondents, both to the internet survey and their postal survey, replied that that was the case. Study in Finland, slightly more recently, this was a random population survey. Are you particularly sensitive to loud sounds? 1 in 6 of those individuals. And then an occupational health study done by Paulan, who recently got his PhD as part of this work. It's got a rather low survey response rate and rather more women than men, which is not usually the case in hyperacusis, but that's the data that Johan found in his survey. He found that nearly 1 in 10 people identify as having sound tolerance issues. That's interesting because that's close to the Anderson study. And nearly 2% have been diagnosed by their family doctor as having hyperacusis. Rather higher figures than we might have anticipated. Now, how does this relate to tinnitus? Well, there are figures in the literature, but what I'm going to share with you is that our knowledge here is very sparse indeed. Anari reported a large series of tinnitus patients, rather hyperacusis patients, so patients with a primary complaint of hyperacusis, and nearly 90% of them reported tinnitus. In that work, though, there's no mention of how severe the tinnitus was, whether the tinnitus was the larger problem or the smaller problem, and which came first. If we look through the other end of the telescope, then Yastrabov and many other people have found that of patients with a primary complaint of tinnitus, about 40% of them report hyperacusis. Here's a study from the Tinnitus Research Initiative group based in Regensburg. Nearly 2,000 people on their database, their primary complaint was tinnitus. Do sounds cause you pain or physical discomfort? Over 50%. Those patients with tinnitus and hyperacusis together were in more trouble than the patients with tinnitus alone. So there's some indication of a cumulative problem. Two other studies. Yang and colleague looked at just over 200 people with a primary complaint of tinnitus, about 50-50 unilateral tinnitus, bilateral tinnitus. Here's their hyperacusis rate. In unilateral tinnitus, 13%, bilateral tinnitus, 5%. Not specific, but rather interesting. Nobody's replicated this finding, and that's something that's crying out for a clinical researcher to undertake. De Geest and colleagues are in Belgium. They looked at 81 patients with a primary complaint of tinnitus. About a third of them had sound tolerance issues. They used the hyperacusis questionnaire as their measure, and that correlated very highly with the tinnitus handicap inventory. So highly that you might consider that both of them are measuring a central construct of distress, of handicap, mediated both by tinnitus and hyperacusis, perhaps not independently. Now, what of the pediatric population? I was involved with Amanda Hall and Rachel Humphreys in a study that sampled 7,000 people aged 11, children aged 11, and asked about their hearing, about tinnitus and hyperacusis. At that sample point, just under 4% of that group complained of sound tolerance problems. The risk factors were being male, having had an early readmission to hospital as a baby, but not admission to the special care baby unit. And interestingly, whether your mother had a master's degree or a PhD. If your mother did, the odds ratio of you having hyperacusis was significantly higher. In another study, I looked at 5 tinnitus centres dealing with paediatric tinnitus across Europe and took a sample of all of their referrals for a year of their activity. In the children with a primary complaint of tinnitus, 38% also complained of sound tolerance problems. And that's rather interesting and mirrors the 40% that I was sharing from Pavel Yastrebov earlier. This work has been systematically reviewed by a PhD student of mine from southern Denmark, and you can have a look at her paper, which is open access. If you have problems finding it, then contact me. Now, what of children that have both together? Well, again, this is the study at aged 11, 7,000 children, as I've said. 3% of them had clinically significant tinnitus. That meant it persisted and it was intrusive. Of those, only 10% reported hyperacusis. Of the children with hyperacusis, 40% of them reported tinnitus. So rather divergent figures than we've seen from adults. Now, what does this tell us in terms of an overview of the epidemiology of tinnitus and hyperacusis together? Well, they apparently do co-occur rather frequently. But our data here, our evidence here is very sparse. We really don't have data on which comes first. I could point you to many opinions in the literature. I would be hard pressed to point you towards data. And again, the sparse data only on how relatively severe these are. Is it the case that if you have the two together, they are both problematic? Or is tinnitus a problem and hyperacusis much less so? Or vice versa? We really don't know at the present time. And how do these things go for patients over time? What's the natural history of these symptoms when they co-occur? Again, we really don't have data. Now, how do we measure hyperacusis? There are several possibilities. In terms of a questionnaire, the best to measure is the hyperacusis questionnaire, which was written first in French by Kalfa and colleagues and translated into English. There's also the possibility of doing loudness discomfort measures, but this is very uncomfortable for the patient, and there are big questions to be asked about how reliable it is. It's extremely variable. You also have the opportunity to do stopedial reflexes, but I think these have the disadvantage, again, of being intrusively loud and also not really giving you definitive information. So I think that there's a strong reliance on the history in patients with sound tolerance problems rather than auditory diagnostics. We can discuss that in the questions. I know for some of you, that's a very real question. Now, what are the mechanisms that underpin hyperacusis and tinnitus? Here is some of the literature on my desk. There now is a wide literature, but I'm going to try and summarize it for you. The main concern that people have is over the issue of central auditory gain. This idea that the central auditory system is not passive, but that it's active and dynamic. Now, we know that, of course, because of the strong investment in the auditory brain and the auditory efferent system. 3 times as many efferent fibers at the level of the cochlear nerve as there are afferent fibers. As the auditory processes enter the cortex, 5 times as many efferent downward fibers as there are afferent fibers. And this strongly innervated efferent system is there for a reason, to control the gain of the auditory system. And there are at least 6 different feedback loops between the primary auditory cortex and the cochlea, looking at the input and modulating the gain of the system. In terms of hyperacusis, the present consensus is, I think I've lost the slide there. The present consensus is that this auditory gain is disordered. Let me just see if it appears later. No, this auditory gain is disordered and plates within the brainstem, involving both traditional auditory structures and non-auditory structures, such as the limbic system. Now, how is it possible to explain a complex concept such as auditory gain to a patient in the clinic? This is what I'd do. I'd explain that sensitivity to sound changes in everyday life. In a noisy cafe, when we could go to such places, our auditory system might control the loudness. When we come out onto the quiet of the street, it might open up that auditory gain. And that our sensitivity to sound changes with our emotional state. A noisy neighbour coming home and we dread them playing their music or working in their garden or doing their home improvement project. And our distress with that heightens our central auditory gain. Or a mother concerned about her young child in the night, a problem with its breathing or with it coughing. And that mother's auditory gain will be increased to listen to her baby through the night, to explain to a patient that their sensitivity is set on extremely high. And to also point out that anticipation plays a part in auditory gain. Now, I've got no idea how old you all are, but for any of you who are under 30, this will be a problematic picture because I need to explain it to you. This is a telephone. It's plugged into the wall and it's a very useful device and it's about to ring. This gentleman is waiting for the telephone call, and when the telephone rings, which is the sound that he's expecting, he's going to startle because of his anticipation. He's waiting for a medical test result or a phone call from his lawyer or his bank manager. He's anticipating this keenly, and when the phone call comes, when the phone rings, he's going to startle. So his auditory gain will be potentiated by his anticipation. Now, what do we presently know about tinnitus mechanisms and how might they relate to these gain mechanisms of hyperacusis? Well, 5 of them are under present investigation. The first is an increase in spontaneous activity, and that areas of the brain, particularly within the cochlear nucleus, specifically the dorsal cochlear nucleus, might be disinhibited. The second is the idea that rather than an increase in the intensity of activity, tinnitus is related to an increase in the synchronicity, the organization, the correlation of the activity. Thirdly, this issue of increased central gain has been proposed. Fourthly, network activity. Fifthly, and I'm going to explain this in a moment, a precision model. Now, of these, the network activity has had some recent evidence behind it. This is from a study that was done in Iowa by a group of neurosurgeons and auditory scientists. They had a patient, male, 50 years old, with intractable focal epileptic seizures, and they were going to perform a craniotomy and to identify the foci of the epilepsy and ablate those by radiosurgery. So the patient had a craniotomy and it was possible to measure from the surface of the brain. This patient also had tinnitus that was very easily and strongly inhibited by sound and remained inhibited. So the patient was exhibiting residual inhibition. And that meant the researchers were able to record brain activity with and without the tinnitus present. Here's their indication of what they found. This is complex, but also simple. Imagine it like the work of an ocean sonographer on the surface of the ocean, who's able to determine from their measurements what's happening in the ocean and at the floor of the ocean? How far are things moving? What's the temperature of the water? What fish and other creatures are there down there? In the same way, in this work, it's possible to reach down within the activity of the brain, and they found 3 networks. A network that is driving the tinnitus. That's important because a tinnitus patient would say, when I'm listening to my favorite piece of music or my favorite television program, excuse me, the tinnitus is intrusive and intense. Secondly, a tinnitus memory network. That's important because some patients say, when I wake, I don't hear my tinnitus, but then a few moments after I've woken, the tinnitus returns. There are networks within the brain that remember the tinnitus and cause it to persist. And then the tinnitus network for perception itself. And when we are designing neuromodulation strategies for tinnitus, we need to be mindful which of these 3 that we're looking for. And then this new precision model developed by Will Sedley, looking at how noise at the level of the cochlea can be stochastic or random, but as it processes up through the auditory system, it becomes more precise, more intense, and more intrusive. And that's a very modern understanding of what's happening with tinnitus. But the argument is, and the slide I'm afraid is lost here as well, the argument is that central gain does not describe tinnitus on its own adequately. The argument from neuroscientists is that it is been well documented that auditory gain and cochlear hearing loss are strongly correlated, and an acquired hearing loss is involved with increased central auditory gain. But many patients with acquired hearing loss do not have tinnitus. So it is not obligatory to have tinnitus if you have central auditory gain problems, but central auditory gain problems might be obligatory for developing tinnitus. Now, another way of understanding the relationship between tinnitus and hyperacusis is this kind of relationship, that if a person has hyperacusis, then they're going to be more aware of their tinnitus, they're going to be more anxious, and that anxious will cause more hyperacusis, and anxiety again will feed into that. Apologise for the slides jumping around. That's an easy way to describe the interaction between those different issues in terms of the tinnitus, the hyperacusis, and the emotional state. Now, what is the impact of hyperacusis? How does it converge and diverge with that of tinnitus? Well, this is based on my clinical experience and surveys, but patients with hyperacusis are fearful of injury and exacerbation and sound exposure. As I've described, some of them have pain hyperacusis and are particularly bothered by that. There's a relationship with anxiety and fear that we've described, and they may well describe being emotionally exhausted. Whereas the impact of tinnitus is described in rather different terms. A clear impact upon sleep, and this can be profound, impact upon their concentration, emotional distress, but not necessarily fear, and anxiety. But that's a broad construct and doesn't necessarily point to tinnitus and hyperacusis converging in any meaningful sense. Now, where is this convergence? Well, I think tinnitus and hyperacusis converge because they both occur together. There is a coincidence in the same patients of these 2 symptoms. They're often on the same referral pathway, coming to see audiologists and physicians in their clinics and ENT doctors. And we use much the same clinical skill set to try and help them with their issues. And both tinnitus and hyperacusis are generally worse in unhappy people. And we've described this relationship with anticipation and with anxiety. But there are some strong areas of divergence. Tinnitus is very often strongly lateralized. Hyperacusis, very rarely so. And where it is, there is usually a specific lesion or event, an acoustic shock or a specific lesion. And there's a good case report of a lesion causing unilateral hyperacusis in the insular cortex. Tinnitus is less labile than hyperacusis is less labile than tinnitus. It's less changeable. It's less influenced by external sound. We know that self-help is very beneficial for tinnitus patients. It appears to be markedly less so in patients with hyperacusis. Unlike tinnitus, patients with hyperacusis may feel that they have self-inflicted their problem, may feel shame about that, and may feel socially isolated. Finally, for this slide, tinnitus is a formless percept. At least a third of patients with tinnitus, if you ask them, what does your sound sound like? They can't describe it to you. Whereas patients with hyperacusis, as we've described, the sound is more vivid, more intense. It has more perceptual salience than it would be helpfully the case. And that seems to be a way that tinnitus and hyperacusis diverge. The somatic modulation of tinnitus is common, by which I mean about 2/3 of patients with tinnitus, when you press on their chin, press on their forehead, press on the back of their head, have a marked change in the pitch and intensity of their tinnitus. This is much less the case in hyperacusis. Tinnitus is commonly intermittent. Hyperacusis is consistent and persistent. And there are some things that seem to relate to hyperacusis that seem to have little or no relation to tinnitus. Let's just step inside those for a second. Misophonia, we've discussed. There's strong aversion or rage to a specific sound, eating and sniffing, often a specific family member, and can cause major problems within a family, within a relationship, within quality of life and lived experience. People are arguing about whether this is a primary diagnosis or a marker for deeper psychiatric problems. People are arguing about the prevalence. It appears that in undergraduate populations, it may be really rather common. The strong consideration is of mechanisms involving links between the auditory system and the autonomic nervous system and emotional systems of rage and disgust. Is it related to tinnitus? Probably not. Autism is also related to hyperacusis, but not particularly to tinnitus. Here is a professor of animal behavior who is autistic, who's written extensively about her sound tolerance problems. My hearing is like having a hearing aid with the volume stuck on super loud, picks up everything. I get deluged with sound. So it appears that hyperacusis light experiences can be very intense in autistic people, little indication of tinnitus being a problem. There's little actual research in this area. Here's a study from Professor Dinesh, who had speak just recently on hyperacusis, looking at patients with Asperger's syndrome, found that neither hyperacusis nor tinnitus were particularly strong in those cases, but hyperacusis in 2/3 of people was far more prevalent than tinnitus was. So clearly an important piece of work there. Further work needs doing. So do tinnitus and hyperacusis overlap in a biological sense? Well, yes and no. Firstly, we can't really look to the animal literature, and neuroscientists Eggermont feel that there is major confusion in animal models between tinnitus and hyperacusis, particularly that which has been induced by salicylate. So there seem to be big problems in that differentiation there. But it's common sense to say that, as with tinnitus, hyperacusis must involve the auditory pathway, central auditory systems, and networks of attention and perception. So I think tinnitus and hyperacusis overlap, but are not contiguous. They're not identical as we have come to assume. My analogy would be, in terms of a family relationship, they're cousins rather than siblings or twins, which we've come to assume. Now, what are the clinical implications of this? Well, firstly, that when a patient has both tinnitus and hyperacusis, there may well be major complexity and overlap, both behavioural and biological. One has to understand the particular specific problem that the patient has and develop clear treatment plans to address each of their concern: their hearing loss, their hyperacusis, their tinnitus, their anxiety, and if they have it, their fear. Now, what treatments are available? Let's look at two: cognitive behaviour therapy and sound therapy. Cognitive behaviour therapy has been trialled in hyperacusis. This is a Swedish study, and it was patients who'd been referred to ENT. The study was undertaken by psychologists, but these are standard ENT patients with a primary complaint of hyperacusis. Then Deuris undertook this for her PhD, had 60 patients, used 6 sessions of CBT produced by Emmanuel, and found significant treatment effects for loudness discomfort, the hyperacusis questionnaire, and on measures of quality of life. So CBT does seem to have some efficacy in terms of treating hyperacusis. In terms of tinnitus, this is a recent systematic review in the Cochrane database. If you're over to the right above this mean level here, you can see these are positive treatment effects. So many of the studies in the literature are indicating strong treatment effects for CBT and tinnitus. So it's possible that some form of CBT program could address issues of both tinnitus and hyperacusis. And we've got research ongoing in Cambridge and in Nottingham in the UK at the moment looking at that. What about sound therapy? Well, in children, we use a nighttime bedside device for both hyperacusis and tinnitus. These are cheap and highly effective. For adults, either an ear-level sound device during the day, bedside sound devices uses environmental sound like the rain or the ocean. In terms of their hyperacusis efficacy, I think that what's happening is that they're recalibrating these issues of auditory gain. I do not have patients turn them up and gradually up and gradually up. I get them to leave them at a quiet, consistent level. What then are my conclusions? And we've got time for some questions. I'm concluding that the relationship between tinnitus and hyperacusis is more complex than we've come to assume. That many questions remain regarding the timing of these symptoms, their relative severity, and differences in their impact. I believe that tinnitus and hyperacusis diverge in many ways, and it's my plea that research is urgently needed in this area, and many of you will have large numbers of patients, access to clinical data. This is a powerful resource in us understanding these things. Be delighted for you to be in touch with me. You can do that by Twitter, and I regularly post the research papers that I publish. They're all available for free on Twitter, so look me up on there and join back there. And there's my email if you want to be in touch personally. A plea: we presently have a survey open on ototoxicity with colleagues in Nottingham. It's on the Facebook site for this group. Be really pleased if you'd have a look and see if there are, if you'd be able to answer that. It would make a substantial contribution. Thank you very much for your attention. It's been a delight to talk to you this afternoon. For some of you this morning, for some of you this evening. Do people
Thank you, Professor. Really, it's a great presentation. Thank you very much. And we have learned a lot and we enjoyed a lot. So we have one question from the audience. Then I have a few questions for you, Professor. So the first question is asking about the role of the limbic system in hyperacusis. Just let's to open. So the audience is asking about the role of the limbic system in hyperacusis, and if it's involved at any stage, does it change it into misophonia, or other types of disorders?
Okay, thank you. So clearly the limbic system does have some involvement in hyperacusis. These patients sit in front of you in your clinic room and say, my sensitivity to sound is emotionally immensely distressing for me. So that must be limbic system involvement. However, the limbic system is a rather wide construct, and my understanding is that emotional neuroscientists now are looking at specific areas and potentially looking specifically at the amygdala and their role in mediating fear and auditory learning. Now, the question of misophonia is rather interesting, and whether it's an entirely separate construct from hyperacusis or whether the two are but together, I'm not sure we yet know. People have assumed they're entirely separate, but some of them are people who have a particular agenda. And some of those are people from the psychiatric community who seem determined that misophonia is an entirely psychiatric condition. And I think as audiologists, as audiology physicians, we have to claim some of this territory back, because some patients with misophonia may well have auditory manifestations, and also it may well be possible to help them by masking or reduction of the salience of the sound that they're hearing. So I think there's more to say there. So I hope that answers that very insightful question.
Yeah, so the next question, Professor, is about the rule. Is there any rule for drugs or medication in the treatment of hyperacusis?
Thank you. Well, remember, I'm a scientific clinician rather than a prescribing clinician, so I can't advise you on your prescription, but clearly in some patients who are extremely anxious, the use of anxiolytic medication, so some non-habit forming medication ideally might well be very helpful. But in general, we don't have particular medication for hyperacusis. There are some medications for neuropathic pain that I think are rather interesting in terms of their potential role in hyperacusis, so watch this space. But I don't think there's anything other than anti-anxiety medication that you can prescribe at the present time.
We have another question, Professor, asking about it's the history and the subjective complaints which we base the diagnosis of hyperacusis just based on this subjective assessment. Like the audience is asking, it's not clear that we have some sort of objective assessment for hyperacusis. So it's all about the questionnaire, the history, the presentation, or what else can be done.
I'm afraid that we're in a rather frustrating situation where we do have to rely on the history. I know it's very tempting to go for loudness discomfort measures, but let's have a think about an orthopedic colleague who was specializing in patients who had ankle fractures. He could measure how far patients with those ankle fractures could kick a soccer ball. And when they'd healed, how much further could they kick a soccer ball, and do statistics on how much better they were after the ankle had healed. But that would be a spurious measure, and it would hurt the patients and it would damage them. And I think very often the measurement of loudness discomfort levels both hurts patients, and in some cases it can damage them. I don't think acoustic reflexes have a particular role, but in Nottingham we're looking at wide band click evoked middle ear myoclonic reflexes, and it's possible that they have got some research role that might be rather helpful. But at the present time, I think we're stuck with the history.
I have a question, Professor. I used to know, I have been told that is hyperacusis and tinnitus, they are two faces for the same coin. So this is the first point. Second point, I have learned it clearly that whenever you have hyperacusis combined with tinnitus, you have to treat the hyperacusis first. So we would like to hear your opinion about this.
Thank you. I think I've let you know that my opinion is that tinnitus and hyperacusis diverge quite markedly. And our view that they're two sides of the same coin may well not have been clear thinking of us over time. I've taught about that, I've written about that, and now think I'm changing my mind. Secondly, I've also heard people say with absolute certainty, when tinnitus and hyperacusis occur together, what you must do is treat the hyperacusis first. But that certainty is not based on clinical trials or evidence. And I think as a profession, we need to be growing up into doing clinical trials and having evidence for the treatments that we do. I think that might well be right, but I think I'm wanting to see colleagues undertaking trials that prove that that's the case. But thank you for those observations, which are helpful and powerful.
Just one more question. It will be the last question, Professor. The audience is asking about the management of pain hyperacusis or hyperacusis associated with pain. So,
thank you. That's very helpful. At present, explanation seems to be really helpful. You're telling the patient that this is real, that you're legitimizing it and authenticating their experience. Secondly, some of these patients will be using hearing protection and might need to do that. In terms of research, I think pain hyperacusis is an obvious candidate for looking at neuropathic pain medication. I think there's some big research needs to be done there. And I think that's a very interesting question that you've asked.
Two more points would like you to clarify. So the first point I asked you before the webinar, people, they have some debate about if the main complaint of the patient is tinnitus or hyperacusis. Do the audiologist have to test acoustic reflexes or just skip it? So this is the first point. The audience wants to hear your opinion and advice about this. The second point is if you can highlight the role of sound therapy in the treatment of hyperacusis. There is a rule, and if there is a rule, how it should be conducted. As those, the last two questions.
Very quick answers then, because we're running out of time. Firstly, acoustic reflexes, skip them. I think they have no value. I think ABR has no value, and both of them are high intensity measures. I think you should skip them. Sound therapy in terms of hyperacusis, I think we need to be doing clinical trials here, but I think there is a strong role for this, and I think it's recalibrating the auditory system, resetting the auditory gain, and that's something that I think urgently needs clinical studies and research studies.
What about testing the acoustic reflex for patients complaining of tinnitus or hyperacusis? Do the audiologists do complete test or just skip the reflexes?
I think we should not be doing them.
Perfect. Professor, you are not aware, but we have many great professors from different parts in the world attending your webinar. So this is unusual that to have those big names listening, but just because you are a legend in the field. So I pick one question from Professor Wafa Kaf. She's asking about that is hyperacusis could be associated with non-otological disorders. We know that hyperacusis is present with other non-otological disorders. Would the mechanism and management be the same?
Yes, so I think with non-otological disorders, I think you need to look wider than our normal otological diagnostic. So look for Lyme disease, look for several other syndromic things. There's a book chapter by McFarren in a book that I looked at, that I edited, that's very important. Clearly there's a role there for both managing the otological issues and the hyperacusis issues. So that's an insightful question, thank you. I wish I had more time to answer it, but I'm afraid I really do need to be present elsewhere but it's been a joy and a pleasure to be with you this afternoon, and thank you very much for your
Thank you,
kind.
Professor. The feedback is awesome, marvelous. It's extraordinary. Everybody likes your presentation. All of us want to say thank you. Great thanks for your great presentation, input, knowledge. Thank you very much. It has been an honor. And for sure, we'll have you again. Thank you, Professor.
My pleasure. I'd be delighted. Please fill in my questionnaire. Thank you. Bye.
Bye. Bye. Bye. Thank you all for attending the webinar. Thanks for the questions and the interaction and the very positive feedback. Please be tuned. Shortly, we'll have a master class on tinnitus. Announcement will be very soon on our Facebook group. Thank you very much and have a great day. Shalom.